In this presentation, we will discuss the neurological system. The learning objectives for this presentation include the following: describe the normal structures and functions of the nervous system, identify the effects of aging on the nervous system, list data to collect when caring for a patient with a disorder of the nervous system, identify tests used to diagnose disorders of the nervous system, assist in planning nursing care for patients undergoing diagnostic tests for disorders of nervous system, describe common therapeutic measures used for patients with disorders of the nervous system. The multipolar neuron is the most common type of neuron found in the brain and spinal cord. I want you to picture the neuron as a communication cell that sends and receives electrical messages. The cell body, also called the soma, is the control center. It holds the nucleus and keeps the neuron functioning by performing basic metabolic activities. The dendrites are the branch-like extensions coming off the cell body. Their job is to receive incoming signals from other neurons. These signals are always carried toward the cell body. Some neurons have just a few dendrites, while others have hundreds or thousands, depending on how much information they process. Next is the axon. This is the long tube-like fiber that carries electrical impulses away from the cell body. A neuron only has one axon, but that axon can branch extensively. Some axons are very short, and others, like those supplying the leg muscles, can be more than a meter long. Covering the axon is the myelin sheath, a protective fatty layer that helps electrical impulses travel quickly and efficiently. In the peripheral nervous system, this insulation is created by Schwann cells. In the central nervous system, it is created by oligodendrocytes. Myelin is essential for normal motor and sensory function, which is why conditions like multiple sclerosis cause such serious symptoms when myelin breaks down. Between each segment of myelin are small gaps called neurofibril nodes. You may know these as the nodes of Ranvier. These gaps allow the electrical signal to jump rapidly from one node to the next, which is called saltatory conduction. This jumping dramatically speeds up nerve transmission. Finally, at the very end of the axon, we see the synaptic knobs. These small, rounded endings store neurotransmitters, chemical messengers like acetylcholine or dopamine. When a nerve impulse reaches the synaptic knob, the neuron releases these chemicals to pass the signal to the next cell, whether that is another neuron, a muscle cell, or a gland. This is the point where communication between cells actually happens. There are three main types of neurons found in the human nervous system: sensory neurons, interneurons, and motor neurons. Each type has a specific role in how the body receives information, processes it, and responds to it. Understanding these functions helps explain how sensations become actions and how the brain coordinates movement and thought. Sensory neurons, also called afferent neurons, are responsible for detecting changes in the internal or external environment. These changes are called stimuli. Examples include touch, pressure, pain, temperature, and chemical signals such as oxygen or carbon dioxide levels. Sensory neurons send this information toward the central nervous system so the brain and spinal cord can interpret what is happening. Without sensory neurons, the body would have no awareness of its surroundings or its internal needs. Interneurons are found only in the brain and spinal cord. Their role is to act as the link between sensory neurons and motor neurons. They receive incoming information from sensory pathways, process and store that information, and decide what the response should be. Interneurons are responsible for higher-level functions such as learning, memory, reasoning, and emotion. They play a major role in what makes each person's thoughts and behaviors unique. In reflex pathways, interneurons allow the spinal cord to respond quickly without waiting for the brain. Motor neurons, also called efferent neurons, carry instructions from the central nervous system out to the muscles and glands. These neurons cause the body to move, breathe, blink, swallow, and perform every voluntary and involuntary motor activity. They also stimulate glandular cells, for example, telling the sweat glands to produce sweat or the salivary glands to release saliva. Motor neurons are essential for responding to the environment and maintaining body functions. This is a cross-sectional view of the spinal cord. It is essential for understanding how sensory and motor information travels between the body and the brain. The spinal cord is organized into white matter on the outside and gray matter on the inside, forming the classic butterfly or H-shaped structure that you often see in diagrams. White matter surrounds the gray matter and appears white because it contains large amounts of myelin. Myelin acts as insulation for axons, allowing nerve impulses to travel extremely quickly. These bundles of axons are organized into tracts that run up and down the spinal cord. Ascending tracts carry sensory information toward the brain, and descending tracts carry motor signals from the brain to the body. When there is damage to the white matter tracts, such as from trauma or multiple sclerosis, it can severely affect movement and sensation. The central gray matter is where we find the cell bodies of motor neurons and interneurons. It appears gray because it contains little or no myelin. The gray matter is divided into horns, the posterior or dorsal horns, which receive incoming sensory information, and the anterior or ventral horns, which contain the cell bodies of motor neurons that send signals out to the body. In some parts of the spinal cord, such as the thoracic region, there are also lateral horns involved in autonomic nervous system functions. Moving outward, we see the central canal running straight through the middle of the spinal cord. This narrow channel carries cerebrospinal fluid, which helps nourish and protect the spinal cord. Around the spinal cord is the subarachnoid space, where cerebrospinal fluid circulates to cushion the delicate nervous tissue. Outside of that is the epidural space, which is the area where epidural anesthesia is injected during childbirth or certain pain control procedures. This space contains fat, blood vessels, and connective tissue that help protect the spinal cord by providing padding between the spinal cord coverings and the vertebrae. Finally, you can see the spinal nerves branching off from the sides. Each spinal nerve carries both sensory and motor information, making them mixed nerves. These nerves leave the spinal cord and supply movement and sensation to specific regions of the body. Understanding this layout helps explain clinical conditions like spinal cord injuries, epidural anesthesia, herniated discs pressing on nerves, and changes in motor or sensory function related to neurologic disorders. This slide shows the spinal cord from a top-down view, showing how different regions of the spinal cord supply different parts of the body. This is important because spinal cord injuries or nerve compression at specific levels produce predictable motor and sensory changes. As LPNs, understanding spinal nerve distribution helps you assess patients with back injuries, herniated discs, or neurologic disorders. The spinal cord is essentially a long bundle of nerve fibers that extends from the base of the brain down to about the level of the first lumbar vertebra. It does not run the entire length of the spine, which is why lumbar punctures are done at the L3, L4, or L4, L5 levels for safety. Below the end of the spinal cord is a collection of nerve roots called the cauda equina. It gets its name because the nerve roots spread out like a horse's tail, and this area controls sensation and movement in the lower body. Damage to the cauda equina is a medical emergency because it can cause bowel and bladder dysfunction and leg weakness. At the top, the cervical spinal nerves exit the spinal cord and supply the head, neck, shoulders, arms, hands, and the diaphragm. Injuries above the C5 level often result in quadriplegia and can affect breathing because the diaphragm is controlled by the phrenic nerve, which originates from C3, C4, and C5. Below that, the thoracic spinal nerves innervate the intercostal muscles between the ribs, the abdominal muscles, and the muscles of the mid-back. These nerves help support breathing, posture, and trunk stability. Thoracic injuries may impair core strength but typically spare arm function. Next are the lumbar spinal nerves, which control the lower abdominal wall and parts of the thighs and legs. These nerves play a major role in walking, standing, and hip and knee movement. Problems in this area commonly cause pain that radiates down the leg, known as sciatica. At the bottom, the sacral spinal nerves supply the thighs, buttocks, lower legs, feet, and the anal and genital regions. They also control bowel and bladder function, as well as sexual function. Damage to the sacral nerves can cause loss of sensation or paralysis in the legs, but it may also cause issues with continence or sexual dysfunction. Understanding this map helps you identify whether symptoms match a cervical, thoracic, lumbar, or sacral nerve problem, which is essential for safe nursing assessment and communication with the healthcare team. This slide shows the basic pathway of a reflex arc. A reflex arc is the simplest type of nerve pathway, and it allows the body to respond instantly to certain stimuli without waiting for the brain to process the information. This is why reflexes are so fast. They are protective actions that help maintain posture, prevent injury, and support normal body function. The reflex shown here is the patellar or knee-jerk reflex. It begins with somatic receptors located in the skin, muscles, or tendons. In this case, tapping the patellar tendon causes a quick stretch in the quadriceps muscle. These stretch receptors sense that sudden change and generate a nerve impulse. Next, that impulse travels along afferent or sensory nerve fibers directly into the spinal cord. Sensory neurons always carry information toward the central nervous system. Once the impulse reaches the spinal cord, it does not need to travel all the way to the brain. Instead, it immediately passes to a motor neuron through an interneuron, or in very simple reflexes like this one, sometimes directly synapses with the motor neuron. The motor neuron then sends a signal back out to the quadriceps muscle. This is the efferent or outgoing pathway. The muscle contracts in response, producing the familiar quick kick of the lower leg. This entire process occurs so rapidly that the leg begins to move before the brain even becomes aware of the tap. Reflexes like this are important in nursing assessments. They help evaluate the integrity of the spinal cord and peripheral nerves. Absent, weak, or exaggerated reflexes can signal neurologic problems, electrolyte imbalances, spinal cord injuries, or effects of medications. Understanding this pathway helps you interpret reflex testing accurately during neurologic exams. Let's review the major structural regions of the brain and how they contribute to nervous system function. Understanding these basic divisions helps us make sense of patients' neurologic symptoms because damage to specific areas produces predictable deficits. This is especially important in stroke, head trauma, brain tumors, and conditions such as multiple sclerosis or Parkinson's disease. First, let's look at the cerebrum, which is the largest part of the brain. Its surface is covered with folds called gyri and shallow grooves called sulci. These folds greatly increase the surface area so the brain can contain more neurons and create more complex connections. Deeper grooves are called fissures and help divide the brain into lobes. The cerebrum is responsible for higher-level functions, such as reasoning, judgment, language, memory, sensory interpretation, voluntary movement, and personality. When patients experience a stroke or injury affecting one of the lobes, you may see changes in speech, thought processes, coordination, or sensation. Below the cerebrum is the diencephalon, which includes structures such as the thalamus and hypothalamus. Although small, this region is vital for relaying sensory information, regulating hormones, maintaining homeostasis, and controlling body temperature, hunger, thirst, and sleep-wake cycles. The hypothalamus also influences the autonomic nervous system, affecting heart rate, blood pressure, and digestion. Next is the cerebellum, the second largest part of the brain. It sits at the back of the head and plays a major role in balance, posture, and coordination of voluntary movements. The cerebellum does not initiate movement, but it fine-tunes motor activity so actions are smooth and accurate. Problems in this area cause unsteady gait, difficulty walking, tremors, and poor coordination, symptoms commonly seen in alcohol intoxication, stroke, or cerebellar degeneration. Finally, the brainstem forms the lowest part of the brain and connects directly to the spinal cord. It includes the midbrain, pons, and medulla oblongata. This region controls many automatic functions that keep us alive, such as breathing, heart rate, blood pressure, swallowing, coughing, and temperature regulation. Because of these critical functions, injuries to the brainstem are extremely dangerous and can rapidly become life-threatening. The brainstem is also the pathway for both sensory and motor nerve tracts, traveling between the brain and the rest of the body. Understanding these regions helps you assess neurologic symptoms more accurately and communicate your findings clearly to the healthcare team. The cerebrum and its 4 major lobes. Each lobe has distinct functions, and damage to any one of them produces predictable clinical symptoms. This is essential knowledge for neurologic assessment, especially when caring for patients with stroke, head injuries, or tumors. Let's begin with the frontal lobe, highlighted here at the front of the brain. The frontal lobe plays a major role in voluntary movement through the motor cortex, which sits in the precentral gyrus. The central sulcus forms its posterior border. Movements controlled by this area affect the opposite side of the body, so an injury to the left frontal lobe produces right-sided weakness or paralysis. The frontal lobe also contains Broca's area, usually in the left hemisphere, which controls the motor movements involved in speaking. Patients with damage to Broca's area may understand language but struggle to form words. This lobe is also responsible for personality, judgment, reasoning, initiative, and emotional regulation. This is why frontal lobe injuries often result in changes in behavior, impulsiveness, or poor decision-making. Next is the parietal lobe, which sits behind the central sulcus. This lobe receives and interprets sensory information from the skin and muscles, including touch, pressure, pain, temperature, and body awareness. It also plays a role in taste interpretation. When the parietal lobe is damaged, patients may have difficulty recognizing objects by touch or may lose awareness of one side of their body, a condition called neglect. Moving to the back of the brain, we see the occipital lobe, which contains the visual processing centers. This lobe receives input from the eyes and interprets what we see. Injuries here can cause vision loss, visual field cuts, difficulty recognizing objects, or hallucinations, not because of eye damage, but because the brain cannot process the information. Finally, the temporal lobe is located on the sides of the brain, separated from the parietal lobe by the lateral sulcus. The temporal lobe handles hearing, smell, and visual recognition. It is also the home of Wernicke's area, usually on the left side, which allows us to understand spoken language. When Wernicke's area is damaged, patients may speak in long, fluent sentences that lack meaning, and they often do not realize they are not making sense. Together, these lobes allow us to move, think, perceive sensation, understand language, form memories, and interpret what we see and hear. Recognizing which lobe is responsible for which function will help you quickly identify abnormal findings during neurologic checks and communicate concerns clearly to the healthcare team. There are 12 cranial nerves. They have been listed in order on this slide, along with 2 mnemonics that help you remember their names and whether each one is a sensory nerve, motor nerve, or both. The cranial nerves emerge directly from the brain rather than the spinal cord, and they control many essential functions such as vision, hearing, swallowing, facial movement, and smell. Because these nerves are so important in neurologic assessment, nurses must be able to recognize both their names and their basic functions. The cranial nerves originate in the brain and brainstem, and they control the senses, facial movement, swallowing, speech, and vital reflexes. As nurses, especially at the LPN level, your neurological assessments depend on knowing what each nerve does so you can quickly detect early changes in your patient. We begin with cranial nerve Y, the olfactory nerve, which is purely a sensory nerve and is responsible for the sense of smell. Damage to this nerve can occur with head trauma or neurodegenerative diseases, and patients may report the inability to smell food or smoke, which is a safety issue. We never test this nerve using irritating substances like ammonia. Instead, we use something familiar like coffee or peppermint. Cranial nerve 2, the optic nerve, is a sensory nerve that controls vision. When we assess this nerve, we use visual acuity testing, like asking the patient to read printed words, and we use visual field testing to check peripheral vision. Deficits may suggest stroke, increased intracranial pressure, or disorders like glaucoma. Cranial nerve 3, the oculomotor nerve, is a motor nerve that controls most of the eye movements, eyelid elevation, and pupil constriction. When pupils do not react equally or the eyelid droops, it is often related to cranial nerve 3 injury. This nerve is extremely important in neurological checks. Cranial nerve 4, the trochlear nerve, is a motor nerve that controls one eye muscle that allows the eye to move downward and inward. If this nerve is damaged, the patient may have double vision or difficulty going downstairs. Cranial nerve V, the trigeminal nerve, has both sensory and motor functions. It provides facial sensation, including the forehead, cheeks, and jaw. It also controls the muscles used for chewing. When assessing this nerve, we check sensation on both sides of the face and observe jaw movement. Disorders like trigeminal neuralgia can cause severe facial pain. Cranial nerve 6, the abducens nerve, is a motor nerve that controls the lateral movement of the eyes. If this nerve is impaired, the patient may not be able to move the eye outward. This nerve is very sensitive to increased intracranial pressure and may be the first one affected. Cranial nerve 7, the facial nerve, is both a sensory and a motor nerve. It controls facial expressions, taste on the anterior two-thirds of the tongue, and tear and saliva production. When assessing it, we ask the patient to smile, frown, raise eyebrows, or puff their cheeks. Bell's palsy is an example of a condition affecting the facial nerve. Cranial nerve 8, the vestibular nerve, also known as the vestibulocochlear nerve, is a sensory nerve that controls hearing and balance. We can assess this nerve by asking about hearing changes, performing whisper tests, or noticing dizziness, vertigo, or nystagmus. Cranial nerve 9, the glossopharyngeal nerve, is both a sensory and a motor nerve that provides taste to the posterior part of the tongue and helps control swallowing and the gag reflex. It works closely with cranial nerve X, the vagus nerve. Damage to cranial nerve 9 can impact swallowing safety and increase aspiration risk. Cranial nerve X, the vagus nerve, has both sensory and motor functions and is one of the most important in the body. It affects swallowing, voice, the gag reflex, and even heart rate and digestion. When this nerve is impaired, the patient may have a hoarse voice, difficulty swallowing, or a poor cough reflex. The vagus nerve plays a major role in parasympathetic regulation, meaning it slows the heart and promotes rest and digestion. Cranial nerve IQ, the accessory nerve, is a motor nerve and controls the muscles of the neck and shoulders, especially the sternocleidomastoid and trapezius. We assess it by asking the patient to shrug their shoulders against resistance or turn their head. Weakness may indicate spinal cord or nerve damage. Finally, cranial nerve 12, the hypoglossal nerve, is a motor nerve and controls tongue movement. We ask the patient to stick out their tongue and move it side to side. If the tongue deviates to one side, it may indicate a stroke or nerve damage on the affected side. Together, these 12 cranial nerves form a key part of your neurological assessment. When you understand what each nerve controls, you are able to identify early signs of stroke, increased intracranial pressure, facial paralysis, or other neurological issues. This knowledge helps you keep your patients safe and supports timely intervention. The sympathetic division of the autonomic nervous system is often called the fight-or-flight system. This system prepares the body to respond to stress, emergencies, or perceived danger. It increases alertness, redirects blood flow to essential muscles, and activates organs that help us react quickly. The sympathetic nervous system begins in the spinal cord, specifically in the thoracic and lumbar regions. These nerves are called preganglionic neurons. They leave the spinal cord and enter a chain of interconnected ganglia that runs along each side of the vertebral column. These clusters of nerve cell bodies are known as the sympathetic chain ganglia. Because these ganglia are located close to the spinal cord, the preganglionic fibers only need to travel a short distance. Once inside the ganglia, some preganglionic neurons synapse immediately with a postganglionic neuron. Others travel up or down the chain to synapse at a different level, allowing the sympathetic system to coordinate a widespread response throughout the body. A few preganglionic fibers even pass through the chain entirely and synapse in distant collateral ganglia closer to abdominal organs. This arrangement helps the sympathetic system activate large regions of the body almost instantly. The postganglionic fibers that leave the ganglia are unmyelinated and much longer than the preganglionic fibers. These fibers travel to target organs such as the eyes, heart, lungs, liver, stomach, intestines, kidneys, and bladder. Through these pathways, the sympathetic system increases heart rate and blood pressure, dilates the pupils, opens the airways, slows digestion, releases glucose from the liver, and relaxes the bladder. All of these effects help prepare the body for rapid action. For LPNs, it is important to recognize when the sympathetic system is activated, such as during pain, anxiety, shock, or severe respiratory distress. Many medications also work by stimulating or blocking sympathetic pathways. For example, beta blockers reduce heart rate by inhibiting sympathetic activity, while epinephrine enhances it during emergencies. Understanding these pathways helps you anticipate patient responses and monitor for therapeutic or harmful effects. The parasympathetic division of the autonomic nervous system is often called the rest and digest system because it is active during relaxed states. It conserves energy, promotes digestion, and supports normal body maintenance. Unlike the sympathetic system, which prepares the body for emergencies, the parasympathetic system restores balance once the stress has passed. The parasympathetic system originates in two main areas, the brainstem and the sacral spinal cord. The cranial nerves involved are 3, 7, 9, and especially X, the vagus nerve, which carries almost 90% of all parasympathetic signals. These nerves regulate essential automatic functions such as pupil constriction, tear and saliva production, swallowing, heart rate regulation, lung function, stomach motility, and digestive enzyme release. Cranial nerve 3, the oculomotor nerve, carries fibers that control the ciliary muscle and the pupillary constrictor. This allows the eye to focus on near objects and constricts the pupils under normal lighting. Cranial nerve 7, the facial nerve, stimulates tear glands, nasal glands, and some salivary glands. Cranial nerve 9, the glossopharyngeal nerve, also contributes to salivation. Damage to these cranial nerves can cause dry mouth, dry eyes, difficulty focusing the eyes, or impaired swallowing. The most important parasympathetic nerve is the vagus nerve, X. It carries preganglionic fibers from the brain to almost every organ in the thoracic and abdominal cavities: the heart, lungs, stomach, intestines, liver, kidneys, and pancreas. The vagus nerve slows the heart rate, increases digestive activity, stimulates peristalsis, and encourages the release of digestive enzymes. This is why vagal stimulation, such as deep breathing, can calm a racing heart. The parasympathetic system also has a sacral outflow. Pelvic nerves arise from the sacral spinal cord and supply the lower digestive tract and pelvic organs. These nerves promote bladder contraction for urination and increase activity in the colon to support defecation. When these pathways are damaged, such as in spinal cord injuries or diabetic neuropathy, patients may experience constipation, urinary retention, or incontinence. One key structural difference from the sympathetic system is the location of the ganglia. Parasympathetic ganglia are located very close to or inside the target organs, so the preganglionic fibers are long and the postganglionic fibers are short. This arrangement creates more localized and specific responses rather than the widespread activation seen with the sympathetic system. Understanding how the parasympathetic system works helps LPNs anticipate changes in heart rate, bowel function, bladder function, and digestive activity. Many medications, including anticholinergics and cholinergic agonists, directly affect these pathways, so it is essential to recognize the expected physiologic responses. It's important to remember that neurologic changes occur gradually over time and affect thinking, movement, balance, and daily functioning. These changes are considered normal parts of aging, not diseases, but they can increase vulnerability to injury and illness. As LPNs, understanding these changes helps us identify what is expected with aging and what may be a sign of pathology. One major change shown here is decreased blood flow to the brain. As blood vessels stiffen and cardiac output decreases with age, the brain receives less oxygen. This can lead to episodes of syncope, especially when older adults stand up too quickly. Reduced blood flow also contributes to slower mental processing and decreased short-term memory. Another normal change involves the accumulation of lipofuscin, an aging pigment inside nerve cells, and amyloid deposits within blood vessel walls. These deposits interfere with how neurons function and communicate. As a result, older adults may show reduced ability in reasoning, judgment, and orientation. They may take longer to learn new information or complete complex tasks. The slide also highlights a decrease in acetylcholine and a progressive loss of dendrites. Acetylcholine is essential for memory and learning. When levels decline, it becomes harder for older adults to store new memories, recall information quickly, and maintain attention. This is why short-term memory can be especially affected. Reduced dendritic branching means fewer connections between neurons, slowing overall brain communication. A decrease in dopamine is another important age-related change. Dopamine supports smooth, coordinated movement. As dopamine levels decline, motor function weakens. Movements may become slower, balance may be impaired, and the risk of falls increases dramatically. This is not the same as Parkinson's disease, but it reflects the normal neurologic aging process. Finally, aging also decreases postural stability due to changes in the cerebellum, motor pathways, and sensory feedback. Older adults may experience difficulty recovering from small losses of balance. Combined with weaker motor coordination, this significantly increases the risk of falls, one of the most serious health threats in the elderly population. As nurses, recognizing these expected changes helps us plan care focused on safety, fall prevention, cognitive support, and teaching strategies that work well for older adults. It also helps us differentiate normal aging from concerning signs of dementia, stroke, or other neurologic disorders. It's important to understand the major components of a neurological assessment. As LPNs, you play a crucial role in identifying early neurological changes, which may be the first signs of a stroke, increased intracranial pressure, infection, or metabolic imbalance. We begin with the basic neurological assessment, and the first priority is the patient's level of consciousness, LOC. LOC is the earliest and most sensitive indicator of neurological deterioration. We observe whether the patient is alert, drowsy, confused, or unresponsive. After LOC, we assess vital signs because abnormal blood pressure, heart rate, or breathing patterns can signal serious neurological problems. Next, we examine the pupils for size, equality, shape, and reaction to light. Changes here can indicate pressure on cranial nerve 3. We also check strength and movement in all extremities, comparing side to side to look for weakness, paralysis, or asymmetry. Then we assess sensation, which helps identify nerve involvement or spinal cord issues. During the physical assessment, we perform a more detailed look at mental status and orientation, including person, place, time, and situation. We also perform a point of care, or bedside capillary blood glucose check, because hypoglycemia can mimic neurological emergencies, such as stroke. We re-examine pupils, assess muscle function, and evaluate cranial nerves as indicated. In the history, we ask about current symptoms, including onset and progression. Review medications and substances, including alcohol or recreational drugs, because these can cause altered mental status. A surgical history, especially brain, spine, or cardiac procedures, is important. Ask about family history of neurological disorders and evaluate lifestyle factors such as sleep, stress, diet, and substance use. Finally, we collect subjective data, which includes the patient's own description of their mental status, memory, perception, language, and pain. Even mild symptoms such as headache, dizziness, or brief confusion can be significant. As LPNs, your ability to notice and report changes promptly is essential for patient safety. The Glasgow Coma Scale is one of the most widely used tools in healthcare for assessing a patient's level of consciousness. As LPNs, using the Glasgow Coma Scale accurately is essential, especially when caring for patients with head injuries, strokes, neurologic decline, or those receiving sedating medications. The Glasgow Coma Scale gives us an objective, standardized way to communicate changes in a patient's neurologic status. The Glasgow Coma Scale evaluates 3 behaviors: eye-opening, verbal response, and motor response. Each category is scored separately, and the scores are added together for a total score between 3 and 15. A score of 15 indicates a fully alert patient. A score of 8 or less means the patient is in a coma and may require airway support. A score of 3, the lowest possible, indicates deep unconsciousness. The first category is eye-opening. A score of 4 means the patient opens their eyes spontaneously, showing that the brainstem is functioning well. A score of 3 means the patient opens their eyes only when spoken to. A score of 2 means they respond only to painful stimuli, such as a trapezius squeeze or nail bed pressure. A score of 1 means they do not open their eyes at all. Eye response tells us how responsive the patient is to the environment. Next is the verbal response, scored from 1 to 5. A score of 5 means the patient is fully oriented. They know who they are, where they are, and the time. A score of 4 indicates confusion or disorientation. A score of 3 means the patient uses inappropriate or random words. A score of 2 means only incomprehensible sounds, such as moaning. A score of 1 means no verbal response. This category helps us understand how well the patient's higher brain centers are functioning. Finally, we assess motor response, the most important and sensitive indicator of neurologic deterioration. A score of 6 means the patient obeys commands, such as lift your arm. A score of 5 means they localize pain, they purposefully try to move away from it. A score of 4 means they flex or withdraw from pain. A score of 3 indicates abnormal flexion, called decorticate posturing. A score of 2 shows abnormal extension, or decerebrate posturing. This is more serious and often indicates damage to the brainstem. A score of 1 means there is no motor response. Recognizing these patterns helps us identify worsening neurologic status quickly. For LPNs, the key responsibilities include scoring each category accurately, avoiding assumptions, and documenting the findings clearly. Most importantly, any sudden drop in a patient's Glasgow Coma Scale score, even by a single point, must be reported immediately. The Glasgow Coma Scale helps us detect early signs of increased intracranial pressure or neurologic decline, allowing for timely intervention. The 4-score coma scale is another validated tool used to assess a patient's level of consciousness. 4 stands for full outline of unresponsiveness. This scale was created to address some limitations of the Glasgow Coma Scale and is especially useful in patients who are intubated, where verbal response cannot be assessed. Instead of verbal response, the 4-score evaluates brainstem reflexes and respiration, which give us more detailed neurologic information. The scale includes 4 categories: eye response, motor response, brainstem reflexes, and respiration. Each category is scored from 0 to 4 for a maximum total score of 16. A higher score indicates better neurologic function. First is the eye response. A score of 4 means the patient's eyes are open, or they track, look toward you, or blink to command. These behaviors show strong brainstem and cortical activity. A score of 3 means the eyelids open but the patient does not track. A 2 means the eyelids are closed but will open to a loud voice. A 1 indicates the eyelids are closed and open only to pain, and a 0 means the eyelids remain closed even with painful stimulation. This category helps us detect both cortical and brainstem activity. Next is the motor response, which remains one of the most important neurologic indicators. A score of 4 means the patient shows purposeful movement, such as giving a thumbs up, fist, or peace sign. These are used because they require higher-level cortical function. A score of 3 shows localization to pain, which is purposeful. A score of 2 represents flexion to pain. A score of 1 shows extension to pain, and a 0 represents no motor response or generalized myoclonus status, often seen in severe brain injury. The third category, brainstem reflexes, sets the 4-score apart from the GCS. These reflexes give us information about brainstem integrity, which is essential for breathing and survival. A score of 4 means that both the pupil and corneal reflexes are present. A score of 3 indicates one pupil is fixed and dilated. A score of 2 indicates that either the pupil reflex or the corneal reflex is absent. A score of 1 means both are absent. A score of 0 means the pupil, corneal, and cough reflexes are all absent. This represents severe brainstem dysfunction and can be associated with a very poor prognosis. Finally, we assess respiration, which is crucial, especially in critically ill patients. A score of 4 means the patient is not intubated and has a regular breathing pattern. A score of 3 means the patient is not intubated but demonstrates Cheney-Stokes respirations. This pattern is linked to brain injury and systemic illness. A score of 2 means the patient is not intubated and has irregular respirations. A score of 1 means the patient is intubated but is breathing above the ventilator's set rate, showing some independent respiratory effort. A score of 0 indicates the patient is completely dependent on the ventilator or has apnea. As LPNs, the 4-score helps us identify subtle changes in a patient's neurologic status, especially in patients with severe head injuries, strokes, or those in the ICU. This tool is particularly valuable when a patient is intubated because, unlike the GCS, it does not rely on verbal responses. Always document each category separately and report any decline immediately. Early recognition of neurologic deterioration can be life-saving. The NIH Stroke Scale, which is a standardized assessment tool used across all healthcare settings to measure the severity of a stroke. It allows nurses to communicate findings clearly, monitor neurological changes over time, and identify deterioration early. A higher score indicates a more severe neurological deficit. As LPNs, you are often the first to notice subtle changes, so understanding each category is essential. We begin with level of consciousness. This includes how alert the patient is, whether they respond to voice or pain, and whether they appear drowsy or comatose. The LOC questions test orientation by asking the month and age. LOC commands assess the patient's ability to follow simple motor commands, such as opening and closing their eyes or making a fist. These tasks help us evaluate cortical function and attention. Next, we assess best gaze, which looks at horizontal eye movement and identifies gaze palsy or forced deviation caused by brain injury. Visual fields are tested in all quadrants using finger movement or threat to determine if the patient has a partial or complete hemianopia. Facial paresis evaluates movement of the eyebrows, eyes, and mouth to check for lower motor neuron or upper motor neuron facial weakness. Motor strength is evaluated in the arms and legs separately. The arm is assessed by having the patient hold their arm up for 10 seconds, while the leg is assessed by holding it up for 5 seconds. We score whether the limb drifts, resists gravity, or shows no effort at all. This helps us identify motor deficits from strokes affecting the motor cortex or corticospinal tracts. Limb ataxia tells us whether there is damage to the cerebellum by having the patient perform coordinated movements like finger to nose or heel to shin. Sensory testing uses pinprick or light touch to determine whether the patient has partial or complete loss of sensation on one side of the body. Best language evaluates for aphasia by having the patient name objects, read sentences, or describe a picture. Dysarthria is tested by listening to the clarity of speech as the patient repeats words. This tells us whether speech muscles are weak or uncoordinated. Finally, extinction and inattention, also called neglect, identifies whether the patient is ignoring one side of their body or environment, which is common in right hemisphere strokes. Altogether, these assessments give us a complete neurological picture. Even slight changes in the NIH stroke score should be reported immediately because early intervention can prevent permanent damage. Be Fast is one of the most important tools for identifying early signs of a stroke. As LPNs, your ability to recognize these symptoms quickly can make the difference between full recovery and permanent disability. Stroke is a time-dependent emergency. The faster we identify symptoms and activate the stroke protocol, the more brain tissue we can save because every minute without treatment means more neurons dying. The acronym Be Fast helps us remember the most common stroke warning signs. The B stands for balance. Sudden loss of balance, dizziness, or difficulty walking may indicate problems in the cerebellum or brainstem. Patients may report that they feel like the room is spinning or that they cannot coordinate their movements. This is especially important because posterior strokes can be subtle and are often missed. The E stands for eyes. A stroke can cause sudden changes in vision, such as double vision, loss of vision in one eye, or loss of half the visual field. Patients may say they cannot see from one side or that the world looks blurry or dark. Visual changes happen because of decreased blood flow to the occipital lobe or cranial nerves involved in eye movement. The F stands for face drooping. Ask the patient to smile and look for asymmetry. One side may droop or look weaker, which indicates facial nerve involvement. A facial droop is one of the most recognizable stroke symptoms. The A stands for arm weakness. Ask the patient to raise both arms. If one arm drifts downward or cannot be lifted, this suggests motor weakness on one side of the body. Arm weakness is usually linked to damage in the motor cortex or the corticospinal tract. The S stands for speech difficulties. The patient may have slurred speech, trouble finding words, or may speak clearly but the words do not make sense. This occurs when the stroke affects Broca's area, Wernicke's area, or other language centers. The T stands for time. Every minute counts. If any of the Be Fast signs are present, even if they go away, you must activate emergency stroke protocols immediately. This includes calling a stroke alert, checking the time symptoms started, monitoring vital signs, and preparing for imaging such as a CT scan. Quick action is essential because treatments such as thrombolytics or thrombectomy are time-limited. As LPNs, BFAST is not just a memory aid. It's a frontline tool that helps you rapidly identify stroke symptoms, communicate clearly with the healthcare team, and ensure the patient receives life-saving interventions as quickly as possible. Decorticate posturing and decerebrate posturing are involuntary abnormal movements that occur in response to severe brain injury. As LPNs, recognizing these postures immediately is essential because they are signs of significant neurologic deterioration and often indicate increased intracranial pressure or damage to specific areas of the brain. Let's start with decorticate posturing, shown in image A. In decorticate posturing, the patient's arms are flexed toward the body, the elbows are bent, and the wrists and fingers are flexed. The legs may be internally rotated, and the feet may be plantar flexed. You can remember this pattern by thinking toward the core, the arms pull inward. This posture typically indicates damage to the cerebral hemispheres or the corticospinal tract above the level of the brainstem. While serious decorticate posturing generally suggests a higher level of brain function, remaining compared to decerebrate posturing. In image B, we see decerebrate posturing, which is more severe. Here the arms are extended, the elbows are straight, the forearms are pronated, and the wrists and fingers remain flexed. The legs are stiff and extended, and the feet may also be plantar flexed. This posture indicates damage lower in the brainstem, such as involvement of the midbrain or pons. Because the injury is affecting deeper structures responsible for vital functions, decerebrate posturing is associated with a poorer prognosis. It's important to remember that these postures may occur spontaneously or when the patient is stimulated, such as during suctioning or turning. Any transition from decorticate to decerebrate posturing is a medical emergency and must be reported immediately. These signs may indicate increasing pressure, herniation syndromes, or worsening neurologic injury. As LPNs, your responsibility is to recognize these patterns quickly, ensure the patient's airway and safety, avoid unnecessary stimulation, and notify the RN or provider promptly. Accurate documentation of which posture you see and whether it is unilateral or bilateral helps guide the neurologic assessment and treatment plan. On this slide, we are again looking at abnormal posturing, but this image presents the concepts in a simplified way that helps us remember the different positions and what they indicate. Abnormal posturing occurs when there is significant brain injury and the body responds with stereotypical involuntary positions. These are powerful clinical signs that tell us about the level of neurologic damage. Let's review quickly, starting with decorticate posturing, shown on the left. Here the arms flex inward toward the chest, forming the shape of the letter C. This can be remembered by thinking C for decorticiate. The arms pull in toward the core. This posture signals damage to the cerebral hemispheres or the corticospinal tract above the level of the brainstem. It suggests that although the brain is injured, the motor pathways higher up in the brain are still partially functioning. On the right is decerebrate posturing, where the arms are extended and pronated, forming the shape of the letter E. To help remember this, think E for decurebrate. In this posture, the arms straighten out, the wrists rotate inward, and the legs remain stiff. This posture indicates a more severe level of brain injury, affecting lower structures such as the midbrain or the pons. Because the injury is deeper in the central nervous system, decerebrate posturing is generally associated with a worse prognosis than decorticate posturing. The pupils can be assessed using the Perla method. This is a critical part of the neurological exam because the pupils give us information about the brainstem, cranial nerves 2 and 3, and the patient's overall neurologic stability. Small changes in pupil size or reaction can indicate increased intracranial pressure, brain herniation, stroke, or drug effects, so LPNs must perform this assessment accurately and consistently. We begin with the P, pupils equal. This means that both pupils should be approximately the same size. A normal pupil size is typically 2 to 6 millimeters depending on lighting conditions. The gauge shown on the slide is a reference you can use at the bedside. If pupils are unequal or anisocoria, it may be normal for some patients, but it can also indicate serious issues such as stroke, aneurysm, or cranial nerve compression. Always compare today's pupil size to what is documented as the patient's baseline. Next is the E-round. Pupils should be round and symmetrical. An irregular shaped pupil may indicate trauma to the eye, prior surgery, increased intracranial pressure, or certain eye conditions such as glaucoma. Document any irregularity during your assessment. The first R, reactive to light, means that when you shine a light into one eye, both pupils should constrict. This shows that the optic nerve and oculomotor nerve are working together. If the pupil constricts slowly, minimally, or not at all, that is a neurologic red flag. If one pupil dilates instead of constricting, this is extremely concerning and must be reported immediately. The next R, reactive, consensual response, is part of the same test. When you shine a light into one eye, the opposite pupil should also constrict. This helps us verify that the brainstem reflex pathway is intact. Finally, A, accommodation means that the pupils should constrict as the patient focuses on a near object, such as your finger moving toward the bridge of their nose. During accommodation, the pupils constrict and the eyes converge inward. Poor accommodation may be caused by neurologic disease, trauma, or age-related changes such as presbyopia. When performing pupil assessment, always check for size in mm, equality, shape, direct and consensual light response, speed of reaction, accommodation. Any change from previous findings should be reported, especially if accompanied by altered LOC, headache, vomiting, or new weakness. These findings together may indicate increased intracranial pressure, which requires urgent intervention. Laboratory tests used to support neurological assessment. These tests help identify underlying metabolic, infectious, autoimmune, or systemic problems that may be causing neurological symptoms such as confusion, weakness, numbness, seizures, or changes in mental status. As LPNs, you will not interpret these results independently, but you must understand why they are ordered, what abnormalities may suggest, and when to report concerning findings to the RN or provider. We start with thyroid tests. Both hypothyroidism and hyperthyroidism can cause neurological changes. Hypothyroidism may cause slowed cognition, depression, fatigue, and neuropathy, while hyperthyroidism can cause anxiety, tremors, irritability, and restlessness. A TSH and T4 level help identify these disorders. Next is vitamin B12, which is essential for nerve function and myelin formation. Low B12 levels can cause peripheral neuropathy, balance problems, memory loss, and even confusion that mimics dementia. Early detection and treatment with supplementation can reverse many symptoms. A complete blood count, or CBC, helps identify anemia or infection. Anemia can reduce oxygen delivery to the brain, causing fatigue, dizziness, and cognitive changes. Elevated white blood cells may indicate infection, including meningitis or systemic infections that can affect mental status, especially in older adults. Creatine kinase, or CK, is a muscle enzyme that rises when there is muscle breakdown. In neurology, it may be used when muscle weakness, rhabdomyolysis, or neuromuscular disorders such as muscular dystrophy are suspected. Elevated CK can also occur with seizures. The erythrocyte sedimentation rate, or ESR, is a marker of inflammation. A high ESR may indicate inflammatory or autoimmune neurological conditions such as vasculitis, temporal arteritis, or certain neuropathies. Electrolytes are extremely important in neurological assessment. Abnormal sodium, potassium, calcium, and magnesium levels can lead to confusion, seizures, muscle weakness, arrhythmias, and altered mental status. Hyponatremia, for example, is a common cause of neurological decline in hospitalized patients. Hormone levels may include cortisol, sex hormones, and pituitary hormones. Disorders of the endocrine system can cause fatigue, weakness, headaches, vision changes, and cognitive changes. Pituitary dysfunction may also affect neurological status due to mass effects of tumors. Liver function tests are also important because the liver removes toxins from the body. If the liver is impaired, ammonia levels rise, leading to hepatic encephalopathy, which causes confusion, irritability, and even coma. The Venereal Disease Research Laboratory Test, or VDRL, screens for syphilis, which can affect the brain and spinal cord in its later stages, a condition known as neurosyphilis. Symptoms can include confusion, personality changes, tremors, or gait disturbances. Finally, renal function tests check for kidney impairment. Kidneys also remove toxins and regulate electrolytes. Kidney failure can lead to uremic encephalopathy, causing confusion, altered behavior, and neurologic decline. These laboratory tests help us look beyond the nervous system to identify systemic causes of neurological symptoms. Knowing why these tests matter allows you to make meaningful observations and report changes proactively. A lumbar puncture is performed to collect cerebrospinal fluid, or CSF, for diagnostic purposes, such as testing for meningitis, subarachnoid hemorrhage, multiple sclerosis, or central nervous system infections. It may also be done to measure intracranial pressure or administer medications into the intrathecal space. Because this procedure involves piercing the dura and entering the subarachnoid space, meticulous nursing care is essential for patient safety and complication prevention. Before the procedure, the LPN's first responsibility is to confirm that informed consent has been obtained. Consent must be signed by the patient or legal representative, and it must be completed before sedation if sedation is used. The nurse does not obtain consent but verifies that it is present and documented. Next, assist the patient with positioning, which is critical to the success of the lumbar puncture. The two common positions are side lying with the knees drawn toward the chest, also called the fetal position, and sitting while leaning forward over a pillow. Both positions help widen the spaces between the vertebrae, allowing easier needle insertion, usually between L3, L4, or L4, L5, where the spinal cord is no longer present and only the cauda equina remains. After the procedure, the immediate priority is to reduce the patient's risk of a post-lumbar puncture headache, which occurs when CSF pressure drops due to leakage at the puncture site. Traditionally, patients were kept in a flat position for 6 to 8 hours to help reduce this risk. Current evidence varies by institution, so it is correct to follow the HCP's order and facility policy. You will also encourage oral fluids, especially caffeinated beverages if allowed, because hydration supports CSF replenishment and may ease headache symptoms. Next, monitor the puncture site for drainage, bleeding, or signs of CSF leakage, which appears as clear fluid. Notify the RN or provider if leakage or swelling occurs. Continue to assess movement, sensation, and level of comfort in the lower extremities. Numbness, weakness, or tingling should be reported immediately, as these may indicate nerve irritation or rare complications such as hematoma formation. Also assess for headache, stiffness of the neck, or changes in mental status, which may indicate complications, including meningitis or increased intracranial pressure following the procedure. Document your findings carefully and report abnormal changes promptly. LPNs play an essential role in keeping the patient safe, comfortable, and closely monitored before and after a lumbar puncture. A CT scan uses multiple X-ray images to create detailed cross-sectional pictures of organs, bones, and soft tissues. CT scans are commonly used in neurological assessment to detect bleeding, tumors, ischemic strokes, swelling, or structural abnormalities. Because CT is fast and widely available, it is often the first imaging test ordered in an emergency situation such as suspected stroke or head trauma. Before the procedure, the LPN plays an important role in preparing the patient. If a contrast dye is ordered, it is essential to verify the order and ensure that the patient's allergies are reviewed and documented. The most important allergy to check for is an allergy to iodine or shellfish, although current evidence shows shellfish allergy does not automatically predict contrast allergy. Still, the key is ensuring the provider is aware of all allergies. Also screen for a history of contrast reactions, asthma, or kidney disease, as these increase risk for complications. If the patient has anxiety, claustrophobia, or difficulty remaining still, a sedation order may be required. LPNs cannot independently decide on sedation, but they can notify the provider if the patient expresses significant distress or inability to tolerate the procedure. After the scan, if contrast dye was used, encourage the patient to drink fluids unless they are fluid restricted. Hydration helps the kidneys remove the contrast material safely. Teach patients to look out for delayed allergic reactions, which may develop minutes to hours after exposure. Patient teaching is essential. Explain that contrast dye may cause a warm, flushed sensation throughout the body, sometimes described as a wave of heat or a metallic taste in the mouth. These sensations are normal and temporary. However, patients should immediately report any signs of an allergic reaction, such as itching, hives, difficulty breathing, swelling of the face or throat, or sudden anxiety. These reactions require rapid evaluation. By assisting with preparation, monitoring after the scan, and reinforcing teaching, LPNs help ensure the safety, comfort, and understanding of patients undergoing CT imaging. Magnetic resonance imaging, or MRI, uses strong magnetic fields and radio waves, not radiation, to produce detailed images of soft tissues such as the brain, spinal cord, and nerves. Because MRI uses magnetism, safety screening before the procedure is absolutely essential. Before the MRI, it is critical to verify that the patient does not have any implanted metal or medical devices that are not MRI compatible. This includes older pacemakers, certain aneurysm clips, insulin pumps, cochlear implants, implanted stimulators, and any metallic foreign bodies, especially in the eye or head. Even small pieces of metal, like shrapnel, metal fragments from an injury, or older tattoos containing metallic ink, can heat up or move during the scan, which makes this step a major safety priority. Patients must also remove jewelry, hearing aids, dentures with metal, watches, belts, keys, and credit cards because the magnetic field can pull or erase them. MRI machines can be loud and can feel confining, so helping patients manage anxiety is an important nursing role. For patients who are claustrophobic, restless, or experiencing pain, analgesics or sedatives may be ordered. As an LPN, you can administer these medications as ordered and monitor the patient for effects before sending them to imaging. Teaching relaxation techniques, such as deep breathing, visualization, or focusing on a calming thought, helps reduce motion during the scan. Movement can blur images, so preparing the patient to remain still is essential for getting accurate results. After the MRI, there is typically no special post-procedure care because the test is non-invasive and does not involve contrast dye unless specifically ordered. If contrast is used, often gadolinium, the patient may need monitoring for rare allergic reactions, especially if they have kidney impairment. Otherwise, patients can return to normal activity immediately. The main priorities with MRI are thorough safety screening, anxiety reduction, and ensuring the patient can tolerate lying still. These steps help protect the patient and ensure high-quality imaging. An angiogram is a diagnostic procedure used to visualize blood vessels, typically to identify blockages, aneurysms, or vascular malformations. It involves inserting a catheter, usually through the femoral or radial artery, and injecting contrast dye so the vessels can be seen clearly on imaging. Because this procedure involves vascular access and contrast dye, both pre-procedure and post-procedure safety steps are very important for LPNs. Before the procedure, we must verify informed consent because angiograms carry risks such as bleeding, contrast reaction, and vessel injury. If ordered, the patient may need to follow a clear liquid diet to reduce aspiration risk in case sedation is used. You will also need to insert an IV catheter so contrast dye and sedation medications can be administered. Sedation, when ordered, requires careful monitoring of airway, oxygenation, and consciousness both before and after the procedure. After the angiogram, our biggest concern is bleeding or hematoma formation at the catheter site. The artery was punctured, so maintaining pressure at the insertion site is critical. Typically, a sandbag or pressure device remains in place for 3 to 6 hours, depending on facility protocol and provider preference. The patient must remain flat in bed for 4 to 6 hours to prevent bleeding, especially if the femoral artery was used. Flexing the hip too soon can reopen the puncture. Monitoring is a major nursing priority after an angiogram. We check vital signs frequently because drops in blood pressure, increased heart rate, or changes in respiratory status may indicate internal bleeding or contrast reactions. We must assess the catheter insertion site for bleeding, swelling, or a new hematoma. We also check circulation below the insertion site. This includes pulses, skin temperature, color, and sensation in the affected extremity to identify compromised blood flow. This is especially important with femoral access. Finally, encourage fluids to help flush the contrast dye from the kidneys and reduce the risk of contrast-induced nephropathy, particularly in older adults or those with pre-existing renal impairment. These steps ensure patient safety and early identification of complications. A myelogram is a specialized diagnostic procedure used to visualize the spinal cord, nerve roots, and subarachnoid space using contrast dye combined with X-ray or CT imaging. It is typically performed when patients have symptoms such as severe back pain, numbness, weakness, or suspected spinal stenosis, herniated discs, or tumors. Because contrast is injected into the spinal canal, this procedure requires careful pre- and post-procedure nursing care to ensure patient safety. Before the procedure, verify informed consent because this test is invasive and carries risks such as bleeding, infection, seizures, or contrast reactions. It is essential to check for allergies to contrast dye. However, the reference to shellfish is outdated. Current evidence shows there is no connection between shellfish allergy and iodine-based contrast allergy. It is more accurate to ask specifically about prior contrast reactions, asthma, or multiple allergies. Assessing a history of seizures is important because some contrast dyes can lower the seizure threshold, especially in patients with neurological disorders. These patients may need closer monitoring or pre-medication based on provider orders. After the myelogram, nursing care is similar to lumbar puncture care because the contrast is injected into the spinal canal using a needle. Encourage fluids to help flush the contrast dye and reduce the risk of post-procedure headache. Unlike a lumbar puncture where patients often lie flat, after a myelogram, the head of the bed is usually elevated 30 degrees to prevent contrast dye from moving upward toward the brain, which could increase the risk of seizures or neurotoxicity. Continue monitoring for headache, nausea, vomiting, changes in neurological status, or drainage from the puncture site. Any of these may indicate complications such as a CSF leak or increased intracranial pressure. Overall, the LPN's role is focused on patient positioning, safety monitoring, fluid support, and ensuring early recognition of complications. An electroencephalogram, or EEG, is a non-invasive test that measures electrical activity in the brain. It helps diagnose conditions such as seizure disorders, sleep disorders, metabolic encephalopathy, brain injury, or suspected brain death. As LPNs, our role involves preparing the patient so the results are accurate and not affected by outside factors. Before the procedure, it is important to make sure the patient's hair is clean, dry, and free from oils, gels, sprays, or conditioners. These products can prevent the electrodes from adhering or can interfere with electrical conduction, which may distort the tracing. This teaching helps the patient understand why hygiene matters for test accuracy. We must also check for medication orders because some medicines, such as sedatives, tranquilizers, anti-seizure medications, or stimulants, may need to be held prior to testing based on provider instructions. This is crucial because these medications can suppress or mask abnormal brain activity, leading to inaccurate results. The LPN should never independently withhold medications, but should clarify orders with the provider. During the EEG, the patient must remain still, relaxed, and comfortable, as movement, muscle tension, and even blinking can create electrical artifacts that appear on the recording. Explain to the patient that the test is painless and simply involves small electrodes being applied to the scalp with a special conductive paste. After the procedure, standard EEGs do not require special monitoring. The main post-procedure task is to allow or assist the patient to wash their hair to remove the electrode paste or gel. If the patient had a sleep-deprived EEG, emphasize rest and safety afterward, because fatigue may increase fall risk. Encourage the patient to resume regular medications unless the provider gives different instructions. The LPN's goal in caring for patients with neurological or mobility impairments is to protect the patient's function, prevent complications, and keep them as independent as possible. The image on this slide shows a classic example of what can happen when the muscles are not positioned correctly. This patient has developed foot drop, a type of contracture that occurs when the ankle is allowed to stay plantar flexed for too long. This is completely preventable with proper positioning and range of motion support, which is why these therapeutic measures matter. Let's start with moving and positioning. It's essential to maintain functional positions, meaning the joints are aligned in a way that promotes normal movement patterns. For example, keeping the foot at a 90-degree angle helps prevent shortening of the Achilles tendon and avoids foot drop. Good positioning also helps protect the shoulders, hips, and hands from deformities. Avoiding injury is another priority. Patients with neurological deficits may not sense pain, may have muscle weakness, or may be unable to reposition themselves, so careful handling prevents skin tears, falls, and shearing injuries. Preventing contractures is critical because once a contracture forms, it can limit mobility permanently and make routine activities like walking or dressing extremely difficult. Contractures also increase pain and can interfere with hygiene and skin integrity. That is why mobilizing the patient as soon as safely possible is one of the best interventions we can perform. Early movement prevents deconditioning, thrombosis, pressure injuries, and pneumonia. When it comes to activities of daily living, or ADLs, we always encourage independence based on the patient's functional level. Even simple actions like brushing their own teeth or feeding themselves help preserve motor pathways and improve self-esteem. Maintaining a consistent routine helps reduce anxiety, especially in patients with cognitive impairment. And of course, we provide assistance as needed to maintain safety, protect dignity, and prevent fatigue. Our overall goal is to support recovery while protecting function and ensuring quality of life. When caring for patients with neurological disorders, communication can be one of their biggest challenges, and one of ours. This slide highlights 3 common problems you will see: dysarthria, expressive aphasia, and receptive aphasia. Dysarthria is a motor speech problem. The patient knows what they want to say, but the muscles used for speaking are weak or uncoordinated, leading to slurred or difficult speech. Expressive aphasia is different. The patient understands spoken language but cannot express their thoughts clearly. They may speak in short phrases, substitute words incorrectly, or struggle to get words out. Receptive aphasia is the opposite. The patient can speak fluently, but they do not understand what is being said to them, and their own speech may not make sense in context. Because each disorder affects communication differently, our interventions must be tailored. Using care with yes/no questions is important because some patients will automatically say yes, even if they don't understand the question. For expressive aphasia, you may need to gently correct substituted words and offer cues without speaking for the patient. For receptive aphasia, we focus on simplifying our language, using short phrases, and supporting communication with gestures or pictures. Anticipating needs becomes essential because patients might be unable to ask for what they require. Using gestures like pointing, miming, or demonstration can significantly improve understanding and reduce frustration. And above all, we must be patient. Communication can take longer, and rushing only increases anxiety for the patient. Clear communication improves safety, reduces frustration, and preserves dignity. When caring for neurological patients, nutrition and swallowing safety are essential parts of preventing complications like aspiration pneumonia and unintentional weight loss. The first priority is always to evaluate swallowing. Many neurological conditions such as stroke, Parkinson's disease, or severe weakness can impair the muscles needed to move food and liquids safely from the mouth to the esophagus. A swallowing assessment may be performed at the bedside by the nurse, but if there is any concern, we consult speech-language pathology for a full swallowing evaluation. Their recommendations help guide diet texture, liquid consistency, and strategies for safe eating. If swallowing is impaired, we implement interventions that reduce the risk of aspiration. Thickening liquids is a very common measure because thicker fluids move more slowly, giving the patient better control while reducing the risk of choking. Positioning the patient upright at 90 degrees during meals and keeping them upright for at least 30 minutes afterward significantly lowers aspiration risk. While the patient is eating, monitoring the meal is important. This means staying nearby, watching for coughing, pocketing food in the cheeks, and signs of fatigue. For patients who cannot safely take enough nutrition by mouth, we may need to provide enteral feedings through a nasogastric tube or a PEG tube. Tube feeding prevents malnutrition and maintains hydration while still protecting the airway. Through all of this, we collaborate with the healthcare team to ensure the safest, most effective nutritional support based on each patient's functional level. This concludes the presentation. Thank you.